Hello, everyone. My name is Dr. Stephen Fishburne, and I am the Medical Director for Community Health Service as well as BJC's Corporate Health Services. Today, I'm going to talk briefly about coronary calcium scoring, what it is, how the test works, what the results actually mean, and how we can use this information in everyday counseling with patients. This is a topic that comes up a lot in primary care and in community health, especially because so many patients hear about heart scans on television or on social media. Since heart disease remains the leading cause of death in the United States, it is important for us to be comfortable explaining these scans and guiding patients appropriately. So my goal for this presentation is to help you feel confident discussing coronary calcium scores in just a clear, practical, and patient-friendly way. Okay, so before we get into the details, I wanted to outline what we're going to cover today. So first, we're going to define what coronary calcium score actually is, because I think many patients have heard the term but don't really understand what is being measured. We'll talk about how the score is calculated, pretty much just the basics, overview of the CT process, and what the numbers represent. Next, I'll walk through how we interpret the results in real clinical practice, including what different scores ranges mean and how they influence cardiovascular risk discussions. We'll touch on the major organizations and what they recommend, such as the U.S. Preventive Services Task Force, the American College of Cardiology, and the American Heart Association guidelines, as well as the Society of Cardiovascular CT, what they recommend. Their guidance really helps us decide when the test is appropriate. After that, we'll talk about how to counsel patients, since many people become, anxious about the results, or they have unrealistic expectations about what the scan can actually say or do. And finally, we'll look at how to use prevention principles like risk factor modification, lifestyle counseling, and medication decisions to help patients create a practical action plan based on the results of the scan. The coronary artery calcium, or CAC score, is a simple, non-invasive CT scan that measures the amount of calcified plaque in the coronary arteries. So it's done using a low-dose CT scan that is actually synchronized with the heartbeat so that the pictures are clear. During the scan, the patient lies flat on the CT table. EKGs are placed on the chest, and the machine takes rapid images that are gated into the cardiac cycle. So this means that the CT captures pictures at the same point in each heartbeat. This reduces the motion and gives a crisp view of the coronary arteries. The entire process usually takes less than 10 minutes, and patients do not go into a long tunnel, just a short CT opening donut that feels kind of more open than like a traditional MRI. So the number that we get from the test is called the Agatston score, and the score takes into account both the density of the calcium and the area that is covered. So as the score increases, it generally reflects a greater overall burden of calcium and thus atherosclerosis, or hard plaques. One of the reasons this test is popular is it doesn't require any contrast dye, and the radiation exposure is pretty low. It's roughly comparable to that of a mammogram. So it's roughly, it's very, very safe, considered very, very safe. And most hospitals and imaging centers offer it for around $100 to $200, and this is something that patients can choose to pay out of pocket for, and that's because it's rarely covered by insurance plans. So why does this matter? Well, heart disease continues to be the number one cause of death in the United States year after year. Even when we look at the most recent data, heart disease still outranks cancer and every other major cause of mortality. And this figure here, this graph shows or comes directly from the CDC's National Center for Health Statistics. It uses mortality data from 2022 and 2023. The numbers you can see here are age-adjusted death rates for 2022 again and 2023. And even though there's a slight year-to-year variation, heart disease remains the top by a noticeable margin that you can see. And then because of that, anything we can do to better identify cardiovascular risk, especially before symptoms develop in primary prevention, it becomes extremely valuable. So coronary calcium scoring fits into that preventive space. It can give us a way to detect atherosclerosis earlier and have a more meaningful conversation about lifestyles, changes, medications, and long-term risk reduction. So again, why should we even care about coronary calcium scoring? The short answer is because heart disease is still the biggest threat to our patients' health. This slide walks through the life cycle of plaques, specifically atherosclerotic plaques, starting with early soft plaques and then moving towards advanced calcified plaques. In the earliest stages, a type 2 or type 3 lesion, the plaque is mostly soft. It's made of lipids and inflammatory cells. At this point, the calcium score is 0 because no calcifications have formed yet. A 0 score doesn't mean there's absolutely no plaque, but it does mean there's no calcified plaques, and the patient's short-term risk is very low. As the plaque matures, it begins to form a lipid core and then develops fibrous thickening. Eventually, calcium gets deposited as part of the body's attempt to stabilize that area, to stabilize that plaque. When that happens, the calcium score becomes detectable. A small amount of mixed plaque gives a score somewhere between 0 and 100. Once the plaque becomes heavily calcified, usually a score of 100 or more, it signals a higher overall atherosclerotic burden. These patients tend to be in a group where risk increases steadily. At the far end of the spectrum are complicated lesions. These are plaques that can fissure or rupture, leading to thrombosis and to myocardial infarction or heart attack. So the calcium score isn't measuring blockages directly, it's really measuring how much atherosclerotic disease has accumulated over time, which is why risk increases as the score goes up. So how is it calculated? The scanner looks for areas in the coronary arteries that measure above 130 Hounsfield units, which is the threshold that indicates calcium. Once those calcified spots are identified, the Agatston method is used to calculate the score. That method takes into account both the density of the calcium and the area it covers. So small, densely deposits may score similar to a large but less dense deposit. The final number gives us a sense of the total burden of calcified plaques. Interpreting the score is fairly straightforward. A score of 0 means no detectable calcified plaque. A score from 1 to 99 fall in the middle mild range. 100 to about 400 is considered moderate, and anything over 400 represents extensive plaques and higher likelihood of having significant atherosclerotic disease. These ranges help us put the results into context and guide how we counsel patients about their long-term cardiovascular risk. So this is what the calcium actually looks like on the CT scan result. The bright area along the coronary artery here is the calcified plaque, and calcium shows up very clearly on CT because it's so dense. It stands out from the surrounding tissue. It's bright white compared to the darker area of the heart. This is a good example to share with patients because it helps them visualize what we're measuring. We're not looking for blockages or performing a dye study. We're simply identifying and quantifying these bright areas in their heart. The more the deposits we see, the larger or denser they are, the higher the calcium score will be. Here is a table It's coming from a paper that shows the coronary artery calcium score and then what it matches and what we see on the CT image. Score of 0, there's no visible calcium at all. Score of 1 to 99, you start to see small specks of calcified spots in the coronary arteries. By the time the score reaches 100 to 299, the calcium becomes more noticeable and easier to see. Scores in the 300 to 999 range. The image shows dense, well-defined calcified plaques. And when the score is 1,000 or higher, there is extensive calcium throughout the coronary arteries, clearly visible in multiple locations. And the Agatston score is calculated using a computer, so an individual person does not have to sit there and measure each of these areas. So before we get into the formal recommendations, I think it's important to ask a basic question, and that is, if the coronary artery calcium score has so much information from it, if we get so much information, why don't we just screen everyone in the whole country? And I think before we decide who should be tested, we have to understand the evidence behind the test and the limitations of the test. And so coronary artery calcium, like any screening tool, it only helps when the results actually change clinical management and reduce risk. So if the score doesn't affect what we're going to do next, I think it can cause unnecessary anxiety and lead to, other testing, follow-up testing that is not helpful. I think we need to look carefully at all the evidence, and these next few slides are going to review each of the major organizations and their recommendations for coronary artery calcium. So first up is the U.S. Preventive Services Task Force, or USPSTF, and they reviewed coronary calcium score in 2018. They concluded that there wasn't enough evidence at the time to say whether adding coronary artery calcium scores to routine cardiovascular risk assessment provided more benefit than harm. I think you got to understand what they mean by that. They weren't saying that the test is ineffective or it was unsafe. Their statement simply reflects that there were no large randomized controlled trials to show that using coronary artery calcium to guide treatment decision leads to better long-term outcomes like fewer heart attacks or cardiovascular events, at least in 2018. And I will say the USPSTF tends to be very conservative in their recommendations, and they only issue strong recommendations when there's very high quality of evidence. So their position essentially at this point is a neutral one. They're not for or against coronary artery calcium screening. They're just saying the evidence wasn't strong enough in 2018 to formally recommend it for widespread use. And the USPSTF issues different grading of recommendations. So a grade A or B recommendation is sought after. A screening tool or a diagnostic test wants to get an A or B, and that is because A or B recommendations are covered by insurance under the Affordable Care Act. So many organizations want an A or B recommendation. So next is the recommendations from the American College of Cardiology and the American Heart Association. They created guidelines in 2019 that recommend using the coronary artery calcium scoring and using it when the ASCVD, or atherosclerosis cardiovascular disease risk, is uncertain. And this is after we calculate the 10-year risk of having a cardiovascular event. So they don't recommend screening it recommend using it for screening for all people. Instead, they recommend using it to help guide treatment decisions when the risk calculator creates, in that gray zone where we're unsure whether the patient should start statin therapy. So what that means, so for patients in the borderline or intermediate risk range, this is when they have a calculator risk of 5 to 20%, the coronary artery calcium score provides a little bit more detail, a little bit extra clarity. So if the coronary artery calcium score that we get is 0, the guidelines would say it's reasonable to delay starting statin therapy because the patient's short-term risk is likely very low. On the other hand, if the coronary artery calcium is high, meaning it's about around 100 or higher, or in the 75th percentile for age and sex, that's treated as evidence of significant atherosclerosis. And in those cases, the guidelines would say lean towards starting statin therapy. And again, this is only when the ASCVD risk calculation is in that gray zone of 5 to 20%. Overall, the coronary artery calcium from the ACC-AHA just adds to help make that decision. It helps reclassify risk in both directions, either reassuring us when the score is 0 or reinforcing the need for treatment when the score is elevated. So I think it kind of supports a more individualized, evidence-based conversation with patients around prevention. So this slide shows the ASCVD, or atherosclerosis cardiovascular disease risk estimator, used in the 2019 American College of Cardiology, American Heart Association guidelines. It's designed only for primary prevention patients. That means patients who do not already have established cardiovascular disease. So here you can see the calculator pulls together the major risk factors that we evaluate in clinic. This includes age, sex, race, blood pressure, cholesterol values, both HDL and LDL, diabetes status, smoking history, and whether the patient is on treatments such as antihypertensives, statin therapy, or aspirin therapy. And these inputs feed into the pooled cohort equations. These estimate the patient's 10-year risk of having a major cardiovascular event like a heart attack or a stroke. And we use this number to categorize patients into low, borderline, intermediate, or high risk. And this helps guide decisions about prevention therapy, mainly statin therapy and things like lifestyle interventions, diet, and exercise. If someone sits in that borderline or intermediate range, that's when the extra tools like the coronary artery calcium score, can help refine the decision tool. So people who are in the very high risk need that statin therapy for sure, and people who are in the very low risk, less than 5%, we're just going to reemphasize the good, healthy decisions that they're making. They don't need statin therapy or other interventions. And the link at the bottom of the slide goes directly to this calculator, and you can use it when counseling patients about their cardiovascular risk. I think it helps make the discussions more objective and easier for patients to understand, because we can show them exactly where they fall and how modifying their risk factors can change their long-term outcome. This slide shows how we interpret the ASCVD risk and how those categories guide therapy decisions. These cutoffs come from, again, the ACC-AHA guidelines for adults ages 40 to 75 years old, with LDLs between 70 and 190 milligrams per deciliter without a history of diabetes. So over here in the green, this is low risk, under 5%. In this group, the main recommendation is lifestyle modifications only, and we avoid medications unless something else, clearly pushes the risk higher. The borderline risk group is between 5 and 7.5%. Here we think about adding a moderate intensity statin only if the patient has risk elevating factors, so things like chronic kidney disease, high triglycerides, or adding that coronary artery calcium score, and if it was high. The intermediate risk, this is between 7.5% and 20%, is where most of our shared decision-making conversations happen. A moderate intensity statin is usually reasonable, and risk-enhancing factors, matter even more in this group. And this is where, again, obtaining that coronary artery calcium score can be really, really helpful. Remember, a score of 0 in this group would say, probably we don't need statin therapy, whereas above 100 would, really push us to say, yeah, you do need statin therapy. The far right here in the high risk, 20% or higher, these patients benefit from high intensity statins regardless of their coronary artery calcium score. We're going to just go ahead and start them in this group because their risk is so high. The Society of Cardiovascular CT and National Lipid Association similarly support using coronary artery calcium score as an objective way to personalize cardiovascular risk. So similar to the ACC-AHA. Their guidance recommends similar to ACC-AHA, but gives more specific therapeutic thresholds. So they emphasize that the CAC score of 0 carries low risk, and you can defer statin therapy in selected patients. Scores between 0 and 99 favor starting statins, especially in patients over 55 years of age. But once the score reaches 100 or higher, all of the societies recommend starting statin therapy because the risk of event rises a lot after 100. Scores of 300 or more cardiac calcium, coronary artery calcium, represent the highest risk, similar to secondary prevention, and they recommend high intensity statin therapy with an LDL goal below 70 milligrams per deciliter. So they go a little bit further and to say, hey, we're going to recommend a higher dose, and we're going to recommend therapy to get you to your LDLs below 70. That's what this society looks at closely. So overall, these societies' guidelines recommendation, they reinforce that coronary artery calcium is most useful kind of when you're on the fence about treatment. They provide kind of a practical cutoff to guide how aggressive we should be in lipid-lowering medications. When we're talking about statins, the term intensity really refers to how much the medication is expected to lower the LDL cholesterol. It's not really about the strength of the pill itself, but it is about how much the patient's cholesterol will actually drop based on the dose that we prescribe. So a high intensity statin lower LDL by 50% or more. Again, these are used for patients who are at the highest cardiovascular risk. Only 2 statins fall into this category. So atorvastatin, 40 to 80 milligrams, and rosuvastatin, 20 to 40 milligrams. Moderate intensity statins lower LDL by 30 to 49%. Many common used doses fall in the middle category, so atorvastatin 10 to 20% or 20 milligrams, or simvastatin 20 to 40 milligrams. Low intensity statins lower LDL by less than 30%, and they can be used in patients who cannot tolerate higher doses. I think you've got to understand here the dose does matter. Atorvastatin 10 milligrams is not the same as atorvastatin 80 milligrams. So reviewing medication lists or counseling patients, knowing the intensity level helps you understand where the treatment matches their cardiovascular risk. Okay, now let's discuss counseling and clinical implications.
So we have a patient in front of us and they're asking, should I get a CAC score? So who is the ideal candidate for a coronary artery calcium score? So the guidelines from the American College of Cardiology and American Heart Association would suggest that a score is helpful in adults ages 40 to 75 who have an ASCVD risk calculation that is between 5 and 20%, either in the borderline or intermediate risk range. And who should not get a coronary artery calcium score? So the score should not be ordered for people who already have a known ASCVD risk, where the presence of a plaque is already established and the results would not change management. So we would avoid a CAC score in anyone with very high calculated risk above 20%, because those patients already qualify for the highest level of therapy, high intensity therapy with statins. And a CAC score is not appropriate for patients with any sort of active cardiovascular disease symptoms, such as chest pain, shortness of breath, or other symptoms concerning for ischemia. Those individuals need diagnostic testing and not any sort of risk stratification.
Coronary artery calcium scoring can be a valuable tool, but I think it has several important limitations that we need to understand so that we're using the test appropriately. So first, the score only detects calcified plaques. It doesn't see soft, non-calcified plaques, which is especially important because sometimes soft plaques can be the earliest and most rupture-prone form of disease for some people. So a 0 score for those people doesn't mean that the patient has no atherosclerosis and no risk. It only means that there's no visible calcium yet. So this is why you shouldn't have a coronary artery calcium score replace clinical judgment or a traditional risk assessment. Again, it does not replace the ASCVD risk calculator. It only supplements, helps refine risk either up or down when the decision about preventive therapy is uncertain. I think we've discussed this. Another limitation is the potential to create unnecessary anxiety. So even a small amount of calcium present can really be alarming to patients, and some individuals may fixate on this, want further studies, further diagnostic tests done. And we need to counsel patients that mild amounts of calcium is common with age, and it doesn't necessarily indicate imminent danger. So our job is to interpret that score and help patients understand, what it really means. Also, a limitation, we've talked about this, but it has a small but real radiation exposure. So we shouldn't be using this test without clear clinical purpose, and certainly not, in a casual way. Coronary artery calcium has no value, again, in patients with known cardiovascular disease. If someone has coronary artery disease, calcium scoring usually will not change management, and again, it is not appropriate for symptomatic patients. So although these limitations highlight why coronary artery calcium should be used thoughtfully, it's helpful when the test results will guide a decision, and potentially harmful when it is used out of context. So good counseling ensures patient understands what a coronary artery calcium score can and cannot tell us. So when we're counseling patients about their score, I think the goal is to use the result in a way that supports their preferences and their long-term prevention goals. This is where shared decision making is key, because patients differ in how they, balance wanting to do medications versus lifestyle changes, and everyone has different risk tolerances. So we should explain that this score is not a diagnostic test, but just a planning tool, and the number helps you understand the long-term risk, and whether we should adjust their prevention strategy at all. The number only matters if it leads to meaningful change in what we do next. I think some people find a reassurance in a lower score or a score of 0. Other people might feel very anxious about a higher score. So part of the counseling is kind of helping patients interpret the result in the right context and avoid false reassurance or unnecessary alarm. So overall, the test is best used intentionally only when the result will guide management and help patients make an informed, valued, aligned choice. You might ask, well, I got a test done now, how often do I need to repeat it? So scans should only be repeated when the result is likely to change what we do next. So for patients with their first score of 0, the event rate remains pretty low for several years, so repeating the test earlier than 5 years really doesn't provide additional value. Some experts consider a 3 to 5 year interval if a patient risk factors change. For a patient with scores between 1 and 99, repeating the test in 3 to 5 years could be considered if there is still uncertainty about prevention or if treatment decisions were deferred the first time. If the initial scan already led to a clear plan, like starting statins, repeating is usually not necessary. Then for scores of 100 or greater, routine testing rarely changes management. These patients these benefits already benefit from more aggressive prevention, so rescanning tends to not alter treatment. And then we want to avoid repeating the scan if someone has known cardiovascular disease, again has a very high calculated ASCVD risk, or if they have active cardiac symptoms. I want to end by talking about lifestyle changes because this is really the core part of cardiovascular risk reduction for all patients, regardless of their coronary artery calcium score. So to review those, we want to recommend a heart-healthy diet, such as the Mediterranean or DASH diet, to help improve cholesterol, blood pressure, and reduce inflammation. This includes, as you well know, vegetables, fruits, whole grains, beans, nuts, and olive oil, lean proteins like fish and poultry, limited red meats, lowering salts, active added sugars or fried foods, and then lowering sodium and increasing potassium-rich foods. We also want to promote regular physical activity with 150 minutes of moderate exercise each week. And this can include brisk walking, cycling, or other activities that someone can do consistently. At Barnes Care or at the corporate health clinics, we give out exercise prescriptions as one of our best-in-class measures. This prescription details what the patient needs to do in terms of exercise and is actually signed by a provider and given to them at the end of their visit. And those exercise prescriptions have been shown to increase patient physical activity. We want to recommend complete smoking cessation, including avoidance of all cigarettes, vaping, or any secondhand smoke. Weight management is also very important. Even modest, steady weight loss can significantly improve metabolic health. For those who like BMI, remember a healthy BMI is between 18 and 25. And then if you're looking at body fat, acceptable body fat percentages for men 20 to 24% and for women 28 to 32%. Blood pressure guidance, the goal also from the American College of Cardiology, American Heart Association, ideally below 130/80 for blood pressure. For cholesterol management, keeping the LDL below 100 and maintaining healthy HDL levels, usually greater than 40. This can be done through diet, exercise, or both. And then finally, preventing or managing diabetes is essential. Elevated glucose, blood sugar greatly increases cardiovascular risk. So you want to optimize A1C and daily glucose levels to lower long-term complications. So with that, thanks for sticking with me through this presentation. I hope it helped clarify coronary artery calcium. I'll end here, and I'm happy to take any questions you might have. If you want to reach out afterward, you can email me anytime at steven.fishburne@bjc.org. I am always available and glad to help. Thank you so much for listening. Bye-bye.